Thank you to SAGES for allowing me to present my research here today. My name is Angela Guzzetta, and I'm going to be discussing how our proficiency-based curriculum improves FES certification performance. So the disclosures are as follows. In this talk, I'm going to discuss why endoscopy training is so important and some prior research done from our institution. We'll go through the methods of the study, and finally, I'll discuss results and changes we're making to the endoscopy curriculum as a result. So a little bit of background. There is increasing demand, both by credentialing committees and by patients, to have an objective assessment of surgical skills like endoscopy. Fundamentals of Endoscopy is an exam much like FLS. Starting in 2018, residents will be required to have passed FES in order to sit for their qualifying board examinations. The exam consists of two parts. Cognitive skills is a written exam, and manual skills is 5 simulated scenarios to test fundamental endoscopic skills. I just want to clarify a point. This study revolved around giving residents the endoscopic training they needed to be able to pass an objective assessment of endoscopic skills. The result should be that residents are better prepared for the FES exam, but the curriculum is not solely targeted for this purpose. Last year, 6 training programs in Texas cold tested their senior surgical residents. Overall pass rate varied widely from 40 to 100%, and our institution fell at the lowest end of this spectrum. When looking at the results, residents tended to fail cognitive and manual skills sections equally. It seemed that residents needed about 65 colonoscopies or 60 colonoscopies with 103 total endoscopies as a threshold. I'm sorry. As a threshold in order to pass FES. My apologies. In response to this, we developed a curriculum and based the study around the curriculum. This curriculum has 2 portions to address both elements in the FES exam. We use the FES didactic curriculum available on the SAGES website. Residents also trained on 3 benchtop models to improve their skill. These models were chosen because they're inexpensive and within the reach of all surgical programs. Expert times have been tested and validated on these models, and having expert times allows us to set goal times or proficiency times for residents. Of the 5 skills tested in FES, these models help train residents on the more difficult tasks. This is the first model, or the trust model, sorry. This is the first model, or the trust model, of retroflex targeting. We are inside the model in the retroflex view, and you can actually see the stars, which are the targets. The goal is to get the points of the stars within the inner and outer circles and hold that view for 5 seconds before moving on to the next target. This is the MIGHTY model for targeting. A similar arrangement where the target must be acquired within a limited amount of space, and that position must be held while the biopsy forceps is then extended. The final model is the Kyoto model in the case 5 configuration, and you can see here the S loop in the sigmoid colon. So 4th and 5th year residents were invited to participate. We did a 2-hour video training session and introduced them to the FES and the models. Residents then did a survey, did a pretest on the models, and took the FES skills portion of the exam only. Then they took another survey, they trained proficiency on the models, and at the end of the study, residents took the full FES exam and then took another survey. So we had a total of 15 residents which participated and completed all components, and you can see that the demographics are not particularly striking. The pass rate of the manual skills before the curriculum was 53%. Residents spent a total of 3 hours training on the models, about an hour on each. The pass rate for the manual skills after the curriculum was 93%, and this was statistically significantly different from before. The mean pre- and post-skill scores for each of the various skills are here. And one thing to note is the mean score for loop reduction, as we heard in the prior talk, is way down at the bottom. Apologies, the pointer isn't working. So training between pre and post, did not statistically significantly change the score. So not only did we fail to get the score for loop reduction up among other scores with training, we failed to move the score at all. So what are we going to do about this? Well, loop reduction was the weakest skill, and residents actually didn't like our model. None said it was very useful, and nearly half thought it was not very useful or not at all useful. So we settled on adding colonoscopy cases on the GI mentor to the curriculum to increase resident experience and exposure to the maneuvers needed for loop reduction. We had hoped that the curriculum could be effective without GI mentor, since the price of this simulation machine is out of reach for most programs. In the cognitive skills section, the residents spent about 3 hours training on didactics, and the cognitive skills pass rate was 93%. Given the failure of one of our residents on didactics, we're modifying our didactic curriculum, and Sarah Hennessy gave a great talk about this yesterday, because the endoscopy questions are featuring prominently in both written and oral board examinations. We wanted to make sure endoscopy was fully integrated in all years of training. So we're going to add the endoscopy score modules to the junior years of training and keep the FES didactics. So I was driving from Houston from Dallas, and I heard this wonderful segment on the radio about self-handicapping, and that's when somebody under-evaluates their performance. And this is happening more often when a person is uncertain about the task that they're performing or lacks confidence about their performance. And in this case, residents demonstrated self-handicapping when they significantly underestimated their performance on the final FES exam. So we asked them, do you think you passed, after they took the FES exam, but before they knew their score, and they underestimated by 40 percentage points about how they did. So residents may perceive that they're not able to perform endoscopy, and thus may not have the confidence to perform this procedure in practice, when in fact, according to objective performance measures, they may be competent. The bottom line is objective feedback is important not only for credentialing committees and patients, but it's also important for residents. Finally, we correlated skill scores to the number of endoscopies, and work at our institution had indicated that you needed the 65 colonoscopies. All of our residents who met these numbers did pass FES, but most residents did not meet the numbers needed to pass, but passed nonetheless. This suggests that if surgical residents are missing endoscopic skills, simulation training can help bridge these gaps. Thank you to everyone who made my fellowship year so wonderful, and I'll take questions.
Yes, good morning, Dr. Satava from the University of Washington. Thank you. I had two questions relative to study design, one of which you indicated that the study was going to be to proficiency, yet you set a time. By definition, proficiency means that you meet the benchmark score, regardless of the amount of time it takes. There is no such a thing as a passing score with proficiency. Your score is 100%. Second of all, you must have a benchmark. And my question to you is, how did you determine what the score was that they must reach? Normally it is experts set the benchmark by doing the curriculum first of all, and then the average score of experts are determined as the benchmark to which the individual will be able to achieve. Thank you.
So I'll take the second question first. How did we determine? We had experts run through these, and their average time, we took that, trimmed the means, and then added one standard deviation to set those times. The reason that we used time as the marker and not, we discussed using a point scoring system. The issue is that on these skills, you do have to complete it within a certain amount of time. And so we felt that that was an adequate marker of proficiency.
Thank you.